Well, welcome. This is the end of pharmacology. We're going to look at chapter 13, the aerosolized anti-infective agents. And we're also going to look at a couple of others that we don't necessarily aerosolize, but that helps us with our patients. So we're going to define some terms that are related to this, the indications for when would we use them and what is available, and then just different combinations of the different drugs that we also can look at. And how do we give all the administration? Some of them have changed. How do they work for the most part? Okay. And so what do we do with some of them? There's a lot of them in the chapter. You don't have to really know all of them. This pretty well takes care of that. So one that we have is pentamidine. Pentamidine is used if you have AIDS, HIV. And basically, we're going to use this if you have PCP or PJP. Basically, this is your either pneumocystis carinii pneumonia or pneumocystis jirovecii pneumonia. Discussion over as to what's the earlier name. Normally, when you get things like this, different diseases, you name them after the person who found them. It was interesting. I found out this weekend that Parkinson was named after a doctor whose name was Parkinson. So kind of interesting with that. As you can see with these, history one more episodes of PJP or peripheral CD4 plus T4 helper cells. Unfortunately, these are the cells that get attacked by the HIV virus. You can also use it, you can see prophylactically to treat this. We know that it's not the best thing in the world, but unfortunately, it's about the only thing that we have. Nebupint, which is also the same as pentamidine. It does give us local targeted lung delivery, fewer or less side effects compared with systemic administration. Basically, you're going to have to pre-treat. This is another one of those drugs that if you don't pre-treat, you're going to end up with some bronchospasm and some problems with that. So you give 300 milligrams by inhalation once every 4 weeks. Physician can change this if they want to. It's a dry powder, 300 milligrams per vial. You're going to go ahead and reconstitute with 6 mLs of sterile water. You cannot use saline, okay? So that'd be one of the things that you do. Respirguard 2 is the device we use it with. Has to be powered by a flow rate of 5 to 7 liters per minute from a 50 psi gas source. You have to wear protection. You do not want to be exposed to this. So pre-treating with a beta-adrenergic, as I said, you have to give them something to prevent the bronchoconstriction. You can also use a parasympatholytic. Remember, Atrovan is one of them. Very few, if any, cardiac effects, but it also blocks bronchoconstriction, so you can use it for that. And then the particles are very small and basically reduces the airway impaction, increases alveolar deposition. When we're talking in therapeutics too, we're going to talk about particle size with our drugs, and this will make a little bit more sense. Use a nebulizer with one-way valves and an expiratory filter. We don't want this in the environment surrounding us. If the patient takes a mouthpiece out of the mouth, you have to stop it at that point. And nebulizers have to produce what we call an MMD of 1 to 2 microns, really is what it is, to increase your alveolar targeting and decrease large airway deposition and cough production with it. So it's going to be given in a negative pressure room with 6 air changes per hour. This is something you want to remember because when we're delivering medications into negative pressure rooms, that air has to be changed, and most of the time it's 6 air changes per hour. Otherwise, you have to put them in isolation. Sometimes that's a little bit worse trying to keep that out because you have to keep the doors closed. A lot of times when visitors or families come, what happens is they go in, they see their loved one, doesn't have very many people visiting them or working with them. They'll leave the doors open. You tell them that doors have to be closed. And they're sitting there going, yeah, but there's nobody coming in. You know, my poor, whoever you happen to be is kind of lonely and being depressed. So we want people to come by and talk to them. Okay. And there it is, your barrier protection, gloves, mask, eyewear, and screen the patients for HIV infections for TB. Lots of TV in this environment. It's one of the major things that we see when patients get PCT or PGP. Ribavirin or Virazole is for RSV. Most people are going to tell you RSV is only for kids, and we see it during the winter months, and you have some really nasty congestion and cough and things like that. However, an adult can also get RSV. I remember we were talking about this a number of years ago. We were talking about this in class. One of the students had indicated, hey, this is only for kids. And we're going, no, it's also for adults. It's like the common cold for an adult. And so we looked it up, and sure enough, there was a report from Navy recruits that this whole barracks of Navy recruits all ended up with RSV. So anybody tells you it's only for kids, tell them no, it's not. Adults are affected by it also. But here, this is we're going to talk about those infants who have RSV. It's an antiviral, okay? Pentamidine used to be called antiprotozoan. Now they're changing it a little bit as far as that goes. But as far as ribavirin or Virazole is concerned, it is an antiviral. It does work against RSV, influenza, and then the herpes simplex virus. And as you can see, RSV can cause bronchiolitis and pneumonia. Almost all children exposed by age 2. Sometimes very mild, self-limiting. Unfortunately, in some cases, it does cause quite a bit of issues for those children. So you can see ribavirin or Virazole is a 20 milligram per ml solution. It's given by SPAG2. This is your small particle aerosol generator. This is actually the only FDA approved device that you can actually deliver RSV. However, there's some studies done with what they call the Aerogen vibrating mesh nebulizer, and basically they say it's a lot easier. You don't have the problems you do with this bag. Doesn't have FDA approval, so if you were to go in during the time frame where ribavirin were giving, you may or may not see the Aerogen at that point. But the SPAG2 is the device that we normally use. These treatments are 12 to 18 hours a day, minimum of 3 days, but no more than 7. Basically, if you're doing them if the child's on a ventilator, you have to change your filters. You have to put a filter on the end of this either way, but the filter has to be changed every hour because the particles are so small that they clog the filter up and then the medication can't get to the child. Comes as 6 grams of powder in a 100 ml vial, and you just reconstitute it with 300 mLs at this particular point. And it has a very small particle size. Like I said, we're going to talk about that in therapeutics too. If there's a solution left in it, it has to be replaced after 24 hours. So what are some of the side effects? Pulmonary deterioration of your pulmonary function, worsening of your asthma or chronic obstructive disease. Things you can end up with: pneumothorax, apnea, and bacterial pneumonia, cardiovascular instability, including hypotension, cardiac arrest, and digitalis toxicity. So if you're on digitalis, we have to monitor that. Hematologically, affects the blood cells with either oral or parenteral administration, but not with the aerosol, which is really, really good. Reticulocytes, these are immature red blood cells that have been released into circulation. There's about like 1 to 1.5% of those floating around at any given time. And then dermatologically, rash, eyelid erythema, and conjunctivitis are some of the things that you may see. So this is Synagis. It's an indication for use, prevention of serious lower respiratory tract disease caused by the RSV in children. Safety and efficacy established for infants with PPD, which is bronchopulmonary dysplasia. This basically is what we see sometimes with our babies that are put on ventilators. Does a lot of damage to their lungs. Premature infants, less than 35 weeks, and children with congenital heart disease. This one is 15 milligrams per kilo. given IM monthly in RSV season. It's a monoclonal antibody. If you remember, we're trying those with asthma now, and it provides neutralizing fusion inhibiting activity. So you don't get the virus replicating at that particular point in time. Tobramycin is one that you'll talk about if you take care of the patients who have CF. It's used for the management of chronic Pseudomonas, and Pseudomonas happens to be one of the biggest diseases we see in patients with cystic fibrosis. Pseudomonas has a very unique odor to it. It's like a sickly, sweetish type of odor. If you've been around it, it's one of those ones you never forget, okay? And we can use tobramycin as an alternative to IV therapy. This now comes also as the Toby Podhaler. This isn't here at one time. It was just the liquid nebulized solution at that particular point. 300 milligrams twice a day, 28 days consecutively, followed by 28 days off. And you should be nebulized as a single agent in an approved nebulizer. Some of the medications, for example, you can mix your bronchodilators with some of your parasympatholytics. And basically, we see a lot of this, if you remember, with Combivent. That's a combination of albuterol. There's your bronchodilator or beta agonist, and then the Atrovent, which is the parasympatholytic. So there's drugs that we can mix. Mucomyst is another one we sometimes mix with the bronchodilators or the parasympatholytics at that particular point. Tobramycin is one that we do not want to mix. So it's single dose reusable DPI, okay, has 28 milligram caplets. They're prescribed for 28 milligram caplets twice daily for 28 days, and it is a bactericide. The thing about the DPI is the patient has to be able to use it. Most of your DPIs, and we're going to talk about these again in therapeutics too, you have to generate at least 60 liters per minute to be able to use some of these. So it improves pulmonary function, decreases the density of Pseudomonas, reduces the need for intravenous anti-Pseudomonal antibiotics and hospitalization, and it really doesn't have significant bacterial resistance, which are things that we need to watch out for. Clinical indications for aztreonam. Okay, these are to improve symptoms in patients with CF who have Pseudomonas again, okay? Improves the symptoms in it. It's not indicated for patients less than 7 years old, and only studied in patients having an FEV about 25% or below 75% predicted. Has to be reconstituted. As you can see, most of these drugs are being reconstituted. This one is a 2 ml single-use glass vial containing 75 milligrams of liposized medication. Must be mixed with provided 1 ml of sterile diluent. Okay, and this is a 0.17 sodium chloride. Comes in a 28-day kit, and it can be delivered by itself using the Altaria nebulizer system. So you still have to pre-treat this patient to prevent the bronchoconstriction 3 times a day per day for 28 days on and off. Should be refrigerated. Once the kit is ready, it can be stored at room temperature for 28 days. Okay. Okay, so this is Relenza. This is for influenza in adults and children 5 years and over who've been symptomatic for no more than 2 days. The off-label use was for the treatment and prophylaxis of H1N1 influenza A, which was your swine flu. It comes as a DPI, okay, and you take 2 inhalation, that's 2 blisters for a total of 10 milligrams twice a day, approximately 12 hours apart for 5 days. You can get some bronchospasm with this, so if you have pre-existing lung disease, this is something that you may not want to be using. So the adverse effect, there you see bronchospasm, deterioration of lung function in patients with underlying asthma or COPD, under treatment of bacterial infection, which is not a good deal, allergic reactions, and other things we can see with this, GI, respiratory, dizziness, and headache. So respiratory care assessment before the treatment, assess to see what's going on with this patient. Do they really have this disease? With pentamidine, the risk of JP or PCP, just depending on what you see. Ribavirin, presence of severe RSV infection. Tobramycin, chronic Pseudomonas. And then you have your other ones for influenza and things like that. Check your equipment, make sure it's working. There's one, when we talk about Dornase alpha, remember when we talked about that back with the mucolytics, Dornase alpha, when you give the medication, it's given in its own inhaler, and that inhaler has to be changed every day. So you'd have to make sure that your equipment, if that's one of the requirements, has also been changed. You still have to do your initial patient assessment, how's this patient going and doing, and what's going on with them at that particular point. And then you have some antifungal agents. As you can see, amphotericin B is one. You have fungal yeast infections in the lungs. Valley fever is one. That's pretty big out this way. Cocciomycosis. Aspergillus is another one. Sometimes what we see with patients who have cystic fibrosis, that they'll end up with aspergillus as a secondary infection. Candidus is one. Remember, that's your thrush that we saw when we talked about administration of your steroids for patients. So again, assessment during the treatment, we have to monitor these patients, bronchospasm, vital signs. Are they improving? If they're not improving, then we need to get in touch with our physicians. How bad are the side effects? Are they to the point where the drug has to actually be stopped? Long term, we're going to do PFT studies, education regarding the device, and how to use your bedside peak flow meters. So general contraindications, pentamidine, bronchospasm and cough, ribavirin, pregnant caregivers, you should not be exposed to this. Tobramycin and the other ones, basically drug resistance. And Zendemeyer, caution in patients with pre-existing airway disease.